but even though we've got quite a small group, we will get started. So since we do only have a few of us, let's do some introductions so we know who's in the room, and then we can get going. So I'm Chantelle Tomlinson. I'm the QI advisor for the National QI arm of NeoTRIPs. I'm based in the East Midlands, but this capacity is one of sort of advice and support, really. So the trainee committee, the resident committee do all of the hard work in terms of manning the project, and I kind of knock about to help a bit on methodology and design and mechanics. We're really fortunate to just be coming, well, not fortunate it's running out, but we've had some charity funding for the last year, which we're just spending the last little bit of. And that's how we're able to provide the Life QI licenses and some of the other resources that we offer for the Safe Neo project. And for those of you who were involved last year, EBM Quip as well. So I'm going to be walking through a bit of a how-to with some Q&A, and if anyone's got challenges and questions and thoughts that they're facing already, we can dive into a bit of that. But we might as well just go through and introduce. So we'll just go across my screen. So Mervat.
Hi everyone, I'm Mervat Ilyas. I'm SD6 trainee based in Leeds. I'm one of the NeoTRIPs co-lead for quality improvement. And today my colleague, the other co-lead, Rashini, couldn't attend, unfortunately.
Perfect. And Leave or Lever is next on my screen.
Hi, I'm Leva Bull. I'm a neonatal consultant in Cardiff. I do apologise not showing my face, but my camera is broken.
No worries, we all have those days. Lovely to meet you. And then Asma.
Hi there, I'm ST5 in the NICU, and I am just one of the trainee leads for the data collection for the Safe Neo in Evelina.
You didn't need to put just in there. That's a very important role. Thank you very much. Andrea.
Thank you.
Hello, my name is Andrea Warnock. I'm one of the neonatal consultants working in Nottingham, and one of kind of the Airway leads as well, and part of the project.
Thank you, Andrea. Prashanth.
Hi, I'm Prashant. I'm a clinical fellow currently working in Evelina alongside Asma. I'm one of the project leads for this QIP.
And Nonya.
Hello, I'm Naya. I'm one of the ST5 trainees working in Leicester, and I'm one of the East Midlands regional leads.
Fantastic. Welcome. So as I say, even though it's quite a small group, we know that it's a bit of a balance. We know that when we've offered evening webinars, lots of people can't make that for bedtimes and lots of good reasons. When we run lunchtime, lots of people can't get away from work, but we will record the session. And if you have colleagues who want to ask questions and watch the recording and so on, please do feel free to share with them. So I shall share some slides to take us through a bit of an intro. And if anyone does just want to chip in, Mervat, are you happy to keep an eye on any raised hands and chat and things for me? Marvellous. So I'm just going to take you through a bit of a kind of a where it came from, what we're doing and how we're envisaging it works. There's a few areas where I would anticipate we might have a few questions and queries, because we typically do, but do jump in at any stage if you want to expand on something or chat more. So can you all see the Safe Neo slide? Wonderful.
Yeah.
So just a reminder of the team. So Maria and I support the project, but as I already alluded to, Mervat, Rashini, who's doing some clinical work today, and Prashanth are in charge of kind of the running and the oversight of the project, and they're always accessible if you have questions and queries. But there's very much as we've already heard from Nonya, there's a network of regional reps, and had we heard from Asma, we have a network of local reps. So there's multiple kind of tiers of support for the project. So hopefully, whatever your challenge or question or query, there should be someone who will be able to tap you in and help you address it. So the aim for this year, so last year, EBM Quip was a real behemoth of a project, and we had all levels of unit. And this year we've focused, after a lot of careful thought, just on level 3 NICUs. Now, that's not to say this project isn't relevant to other units, and it may well expand over time, but for lots of practical reasons, we're focusing on the level 3s this time. And our aim, as for all of you here will be invested in, is to reduce our rate of unplanned extubations. We know it's a really sticky problem, unplanned extubations. We might have a month where we think, fantastic, we've cracked it, and then the next month our numbers ping back up. At least that's often my experience. So we're really here to see if, by working collaboratively on a national basis, really tapping into each other's expertise and resources and using some additional benefits like our software platform, actually, can we reduce these rates together and keep them down? The project duration is relatively short, so we know that actually this is hopefully going to be a real platform for a Kickstarter for those people who may not have had sort of had such kind of methodology in place before to try and look at reducing their unplanned extubations, or it might just be a nice bit of a sort of injection of support for those who have been looking at it for some time. The team are going to define a specific target in terms of reduction in unplanned extubations once we've got a few months of data to go on. And it was clear to us in the sort of scoping data and in the literature that actually people's rates really vary. And if we're trying to look at kind of high quality QI, therefore we need to have some data before we can kind of refine the targets a little bit. That said, we're all in the same boat of wanting to reduce our rates, and that's what we are here to do. So the what in terms of our measures. So the local reps among you will hopefully already be on LifeQI, have your licenses and have been submitting data. So the 13th of every month is the nominal deadline for the preceding month's data to be entered into the platform, and then that's all collected. We've been having some background conversations around how that data exactly is entered, and I've been talking to LifeQI this morning about a couple of nuances in that we can come to at the end and have a think about what's most useful for teams in terms of the charts that you can take back and share amongst your MDT. But our outcome measure, as will be familiar to lots of us already, is describing our unplanned extubation rate as a rate per 100 ventilation days. So for every 100 ventilation days, how many unplanned extubations are we having? And for our process measures, we're looking at those things that might be associated or affiliated with our rates of unplanned extubation. So the percentage of babies who've had ETT, their endotracheal tube securement, reviewed in the 24 hours prior to their unplanned extubation, the percentage of intubated babies who have been documented to or known to have been evaluated for extubation readiness in the 24 hours prior to their unplanned extubation, and the percentage of intubated babies with an optimal comfort or pain score as per protocol. And so that's defined by what you do where you work. And that's to say, there's a lot in there, we're aware. So firstly, do you have a protocol? Secondly, are you following it? And thirdly, optimal. Have you kind of defined where you work, what optimal is, what scores the babies should be? I think we could have a whole session just looking at that, and we may well as time moves on. But today, suffice to say that actually looking at, have they had an optimal score as per protocol in the 24 hours prior to unplanned extubation? And a balancing measure. So for those of you who haven't done a lot of kind of formal QI previously, the balancing measure describes something which you might expect or could anticipate that you would cause to move in the other direction if you're successful in your QI ventures. So for example, the number of planned extubations which lead to re-intubation within 48 hours, you might anticipate that if you're trying to avoid your unplanned extubations and you're keeping babies perhaps more sedated, and therefore you are trying to extubate them earlier so that they do not have an unplanned extubation, you can see that your number of planned removals of the ET tube, which lead to the baby going back on the vent, may be skewed depending what direction of travel you take. So those are the setup of measures. And as I say, as we move through, you're very welcome to ask any questions about those, how you're inputting those, what those mean, and we can certainly have some conversation around that. Just wanted to touch on, and then Mervat will share a couple of slides with us in a moment, the role of your regional reps. So actually for some of you, your regional rep is in this meeting, which is fantastic. But to just touch on, so local reps we know are very much integral to the local project. You're going to be inputting the data, but where your regional reps sit is we've done the kind of recruitment piece for this project. They are there to distribute and signpost you to either any existing or any new resources that come out. So they're really your first port of call if you need some support around what resources are available. They are working around communication in WhatsApp groups, distribution of emails and newsletters from the core group at NeoTRIPs, thinking about multidisciplinary collaboration. So last year our regional reps did all kinds of interesting things like some regional workshops, some webinars among the groups. Now clearly, as this is a smaller project, you may have one, two, a few units taking part in your region, but actually coming together can be extremely valuable. Troubleshooting issues and then escalating it up to the core team if needed. Really looking at sustainability and helping you to work on how are you going to work on some of this after the actual core project data term ends, and supporting you with your timely data entry. So contacting every month out to the local reps and saying, have you had any problems with getting your data in? What can I do to help you get that in? And it's really that really important bridge between the central committee and the planning and the data oversight, and actually how things are really happening kind of on the shop floor. So we thought we'd just take you through a bit of an overview of those. So if I stop sharing for a moment, Mervat, is this a good time for you to share your information?
Yes. Can you see my slides?
I can indeed.
Yes. So we had 22 units across the UK participating in
Not just me, it sounds like. I think Mervat's frozen completely if it looks like that for everyone.
I couldn't hear anything.
Perfect. But can people hear me?
Yeah.
Yeah, I can hear you.
Okay.
Yeah.
So we'll presume poor Mervat's lost her Wi-Fi or something for a moment, and we'll return to the slides we were on, and then we can come back to that. So are we back to the role of your regional rep slide for everyone now?
Yeah.
Wonderful. Yes. Great, thank you. So we'll move forwards a little bit. So the resources, there are kind of a whole bundle, a whole package and a real evolution of resources for the project. So from a NeoTRIPs central point of view, there's the monthly webinars where we will either sometimes pick a topic related to QI and methodology and drill down into that, and it might be a little bit more kind of skills based. There's lunch and learn sessions around all sorts of topics centrally for NeoTRIPs, and that might be a real theoretical kind of educational topic, that might be something really practical, that might be a particular journal club related to a part of the Safe Neo project. The Life QI platform is obviously a huge resource, and that's our biggest expenditure for the project. So everyone having a license to be able to use that project, not just for your data entry, but also to really use it as a tool in your department and among your local team, is something that we really want to empower you to do. So if you're not familiar with Life QI and you haven't used it before, then we really want you to support you to make the most out of that, and we can come to that in a moment. Associated to that are the driver diagram and change ideas. Now we're going to come to that in some detail detail in a moment, but that's something else that we really want to support you to use and make the most of. And then all of our online resources can also be found and will be updated on the NeoTRIPs website. Like I said, anything you can't find, your regional reps will be the first port of call for signposting you to resources, but the Central Committee are always there to offer any additional support if regional reps aren't able to access what you need. So we'll go through the driver diagram in a little bit of detail. One of the things we found last year was that some people were really familiar with using a driver diagram to kind of push and to execute their quality improvement locally, and some teams not so much. So we'll go through it in a little bit of detail. And so what a driver diagram does, as many of you will know, is describe what we're trying to do and then essentially describe the conditions required and the things needed to enable that to happen. So this is all about working through what will enable this change and then coming through what are the change ideas that you could link to PDSA cycles. It is not exhaustive and we want to build it up and we want to flesh it out. So if there's things that you're doing locally or you're thinking about doing, let us know. And then what we can do as a core committee is populate more into the change ideas, and then you can map your PDSA cycles to those, and they also provide ideas for other people as well. So we are all working towards reducing our rate of unplanned extubations, in this instance, in level 3 NICUs, and we're looking at that in this particular context over a 6-month period, but very much with the view that for some of you this is going to be one piece of a really long-term project, and we hope that for many of you this might just be a bit of an accelerator, a little bit of a leg up if you are needing a bit more resource and a bit more help, and then we're going to work at looking at all of this data together. So to take you through the different areas, so the different sets of primary drivers that we have are improving patient-centred care. So when I walk through the IPCC drivers and change ideas, they all relate to improving patient-centred care. So for domain 1 of improving patient-centred care, we've got comfort and sedation scoring. And so just one example of a change idea, and actually this probably breaks down into many, so daily comfort scoring and a review of sedation to achieve your local targets. Now, actually, if you work in a unit where you don't have a clear kind of SOP or guideline around optimal comfort and sedation, or what optimal is, that change idea may break down into a lot of different elements for you to actually facilitate that. So domain 1, improving patient-centred care there. Domain 2 in improving patient-centred care is extubation readiness assessment. And so, again, that could look like all sorts of things, but just 2 ideas would be training and documentation on extubation readiness as per local policy. Now, again, that underpins, firstly, do you have a local policy or guideline or setup for how you would be evaluating extubation readiness? If you don't, that might be step 1. If you do people know about it? If they do people do it? And if they do they write it down? So as you can see, there's a whole load of potential change ideas in there as individual or potentially even simultaneous PDSA cycles. And just to say again, if anything springs to mind for any of those who weren't here at the very first few minutes, please do just raise a hand or even jump in if you feel someone hasn't seen you, raise a hand and we can chat and ask questions as we go along. So the third domain in improving patient-centred care would be 2-person holding as per local policy. Again, clearly there has to be a policy if we're going to do that. And ideas may be, for example, that you implement that during ET fixation, cares, procedures, scans, handling. We'll come to some examples of some QI projects where people have done that. And then also in this, the next part would come to safe equipment use and standardisation. So safe equipment and standardisation, SES 1. So the first part of safely using our equipment and standardising its use would be daily review of endotracheal tube position and securement. And so for that to happen, change ideas might be standardising your documentation if you don't already have it on position, length and securement on daily ward rounds, for example. Regularly assessing for skin integrity to minimise the risk of dislodgement. Now, what we're not setting out to do here as a central team is say you must use X as your method of fixation. This isn't about that. If your interpretation of the evidence is that X, Y or Z method of fixation in your hands is the best one to use for all kinds of reasons, and that might depend whether you're a surgical unit, whether you have predominantly teeny tiny prems, whatever your setup is, actually, we're not here to say this is what you must do. We're just going to support you to evaluate that and make the very best of it that you can. So regular skin assessments, using timeouts before procedures, for example. So if it's not well embedded where you work, that actually before an X-ray, for example, quite aside from there being a policy and practice of 2 people handling that baby for an X-ray, is there a practice of people stopping, evaluating the endotracheal tube and ensuring that they're happy with it before that happens, with a process of what to do if they're not? So in the safe equipment standardisation component part 2, you would have training and education. And just one example might be simulation training around your ET tube. It might look like all sorts of things. So some units have trolley dashes where they try and educate around safely using equipment and standardising its practice. There's all kinds of things you could do, but help us to populate this with change ideas broader than just simulation, and then we can share great work that's going on with other people. And then the next domain is staff awareness of rates. So are your staff, are your MDTs aware of your unplanned extubation rate on your unit? I think we're all quite good at receiving hundreds of emails, be that normothermia, unplanned extubations, whatever it is that our unit is working really hard on, but actually making people aware so they can use that in a really meaningful way is a slightly separate challenge in terms of a step up from that. That said, that's a really good start if you don't have it. But in terms of monitoring, so that your staff can be aware, do you have a standardised reporting template and do you use the DATIX system to report your unplanned extubations? Do you have, for example, QR codes to make reporting really easy for people? So make the thing you want them to do the easiest thing to do. And do you present this specifically at your governance meetings? Some people have QI huddles on a weekly or monthly basis where they talk about this stuff. So whatever you think might work in your hands to improve your monitoring will in turn then enable better staff awareness. And so domain 2 of staff awareness of rates would be thinking about communication among your team. So actually, in terms of that awareness of the important nature of this, is there really open communication on your unit that if there's a concern about the stability and fixation of an ET tube, that is an urgent and prioritised task? Do you have something like posters saying number of days since your last unplanned extubation? Or you might not think that's a useful metric in your unit. It may be disheartening in the early days of getting your project really embedded. So whatever it might be that you feel would be an important measure is something that you can use and display. In terms of the platform we're using for data collection, this code is a link through to the LifeQI training. So for local reps in particular, if you haven't seen the training video or had access to that, there's actually tons of training available just from LifeQI on their broader website. But this is a link through to one of the specific pieces of training on LifeQI. I'll pause for a second if anyone's got any questions on that last section, or not necessarily, not specifically about that, but either relating to the driver diagram or the measures. Has anyone got anything they want to ask or flag?
There's nothing in the chat.
You're back, Mervat.
I'm
Thank you.
back. Sorry, I had to restart my laptop.
No worries. We all kind of just thought maybe you'd frozen for a second, but you didn't come back. So there you are. Super. So we'll come back for a bit of Q&A at the end of this section then. Clearly, what's going to underpin all of this is knowing your local data. So you might have a really mature system for exploring this. You may struggle to get the kind of approach going so that on a regular basis you are knowing, updating and communicating all of this. So this is lifted from a really recent publication in a NICU context of trying to reduce unplanned extubations. And as you can see, just if you were to look at the sort of colour graphics on this, actually this team looked at the reasons for their unplanned extubations, and you can see that during cycles 1, 2 and 3 of their QI, their reasons for their unplanned extubation changed. And I really wanted to bring this slide into this presentation because I think this really highlights for me something that people who know me will hear me wax on about all the time, is that you have to understand the why in your data. So, for example, in this project, you could be really tricked into thinking you're not making a change. You could see not much overall change in your unplanned extubation rates, for instance, or you may see them bob down and then creep up. And we know that, for example, that's why we've got balancing measures, but also it's really common if you solve one problem that's causing something like an unplanned extubation, you can oftentimes just trade it for something else. So, for example, in the first cycle, this team had unknown reasons as quite a significant data set here, which is something that lots of us may struggle with. They had no unplanned extubations over on the right side of this chart during cuddles with parents. They had a couple relating to secretions or during a head scan. But during NIPEs, examinations, handling, X-ray transport, they had this sort of consistent handling type challenge. Now, we'll come to what they did in a moment. During their second cycle, they clearly had a really big preponderance of vomiting or suction related incidents, but then actually in their third cycle, they didn't have any during X-ray, they didn't have any during transport, they didn't have any during suction, but we're now seeing these ones where potentially, because people are more comfortable and confident with it, they may be, just for instance, facilitating a lot more cuddles with parents, and so the number of unplanned extubations we see occurring during cuddles with parents is going up. We're now seeing them occurring during procedures or related to secretions. So it's really important to know your local data, know who is going to really drill down into it so that you can try and stay on top of what it is that's causing it, because it can really blend over time and morph from one set of reasons to another. And this has got too much detail, but to give you an overview of those teams that are recording this data year after year after year, there are periods where things get better and things get worse, and that's real life. But what they did when we look into how they've drilled down into certain things was identifying their problems. So data capture is an initial problem, documentation of reasons behind unplanned extubations is a real problem. Then when they did some work on reporting, looking at a pro forma and educating their staff, they actually saw their rates go up. Now that's okay. You have to know what's truly going on. So in this 2020 period where they had 0s, 1s and 2s for their rate per 100 ventilation days, once they looked at their data capture, that's not really what was happening. So they didn't get worse once they started the project. They just started really understanding what was happening. They then start to identify what's happening, and this can be a really sticky time. So you see that overall, if we analyse this signal, they may well have seen their rates get worse before they got better, but that might relate to some of the SOPs and some of the priorities that they've chosen to adopt. They've then looked at things like baby movement, adjustment of ET tubes being underlying causes for unplanned extubations, and then done some more work on staff education and monitoring of how the ET tubes are fixed, before actually entering this phase where they saw, even if it wouldn't be statistically a reduction, they have actually seen that month on month for them, overall, the mean of their values, so the average rate is coming down. And this is one of the nice things about us providing the Life QI platform for this, is that actually you can really drill down into your own data with the U charts that we're using for this project and try and unpick quite a lot about what's going on with your rates and monitor it through your PDSAs. Something that's hard to do, but often worth it, is the parent perspective in QI. So I'm just going to touch on it for a couple of slides. Excuse me. And so we know from international work, and that's a lot of that's been done in the US or in Canada, but we know that if you ask patients to engage in patient safety, there are certain barriers and certain benefits, and that's no different from engaging parents and carers. Now, it's a really thorny and sensitive issue, and how people frame engaging caregivers in patient safety can be really challenging. It can be a really tough conversation. And I think understandably, there's lots of reticence that if you start trying to unpick patient safety with a family, number one, there's that hurdle of kind of perhaps demonstrating a problem to them that they didn't know was there. And there can be that real perception of actually, you don't want to tell them we're having this real challenge in keeping your baby safe and we're not sure how to fix it. However, we know that this is just an example from one study. If you ask parents, they want to advocate for their families and their babies. And it's really astounding what they know and they pick up and they see anyway. The things that they're internalizing are already present. If you ask them why an unplanned extubation happened, it would probably be a far quicker method of getting to the bottom of things than trying to analyse the datics when they are present. And we know that these domains are what are important to families when we break down their engagement with patient safety. So a lot of what it boils down to is, are you involving me and helping me understand that you're watching over my baby and that you're letting me take part in making decisions? And that comes into physical safety, developmental safety, and emotional safety. And actually, the physical safety piece is where we might put something like unplanned extubations, but it comes into the whole thing in terms of what we're trying to achieve. But actually empowering parents to advocate for their baby in this domain of physical safety is highly likely, based on what we know, to overall improve their experience of feeling engaged and feeling safe. There are, of course, barriers and challenges to that. And if you have a high rate of unplanned extubation, it is really difficult, but they are there and they are caring for their babies anyway. So engaging them in the process can be, when done judiciously, a really beneficial one. We know that actually to engage parent or carer partners, it's got to be done to a certain standard. So actually, they have to be able to have some knowledge that's relevant to your local context to be able to be partners in safer care. They have to be supported to take part in whatever way. So if you are trying to empower them to either co-design or co-produce a piece of work, to actually advocate for their baby, for example, you're going to have to figure out how you empower them to do that in a way that's meaningful and acceptable to your whole MDT. Your maternity and neonatal voices partnership may be really helpful in how you frame or go about any parent-carer engagement work. And actually how you get it to be co-production rather than tokenism, where you've asked parents what they think, but then you're not truly engaging that with what you're doing, can be a hurdle, but one that's absolutely worth getting over. It may be that you're just sharing guidance with them. It may be that you want their input into guidance, but whichever way round that is really valid in engaging them in it. They may have a really good idea to offer you of what is going on as work as done in your unit. So we all have a concept of work as imagined where we work, but parents and carers are often the people who can see every day how work is really done and what's really going on. What they observe and us listening to that, though may be really challenging, can be really beneficial. And like I say, ultimately, what they say in the literature that is out there is that it gives them this sense of being able to advocate for their baby. They may not be able to prevent things from happening any more than we can, but they may feel able to advocate and to therefore take part in improving the outcome for their babies. I'm not here to say that it isn't without challenge, and it's a really challenging area, but actually, if we're going to do it properly, and if we really want to have the whole MDT involved in reducing unplanned extubations, parents are a really key piece to at least consider in that puzzle. The immediate what now is to have time for some questions, some thoughts, talk a little bit about what your local experience of the project might be already. We've had a few people join since we just started, which is wonderful. And then we can talk a little bit about some other kind of stuff moving forward. So future webinars can focus on any different elements, but we wanted to do a little bit of the sort of mechanics. So just things that you've experienced already, questions that you have, anything you're not sure about, please do get the ball rolling and ask us.